Hi, this is it's Colin from the Macular Society. Thank you for joining our session today. We're doing a special session again on sort of specific conditions, and today we're joined by Professor Peter Issa from Oxford Eye Hospital to talk about PXE. But before we get on with that, let's a little bit of housekeeping stuff. So if you would be kind enough to leave yourselves on mute and your cameras off, and please don't accidentally share any screens, because it does happen from time to time. So if you could just sort of not do that, that would be great. There is a function going where you can talk, send messages and bits and pieces, but we're quite thin on the ground today. So I think what we're going to do today is we're going to let Peter give his presentation, and then we might let might just ask people to unmute themselves and ask questions, I think, because we are a bit low on the ground. But I think Geraldine, who will sort of keep half an eye on the chat box, I think. So if there's any questions that we miss, I'm sure we'll get to them. So just to let you know who I am, I'm Colin Daniels, and I'm the Working Age and Young Person Service Manager for the Macular Society. It's a relatively new service, and this is a relatively new part of the program that we're trying to organise, because it did become very apparent that quite a lot of time we were talking mostly about age-related macular degeneration, which is great because that obviously is the biggest form of sight loss in the Western world. But there are other sort of macular conditions for people, you know, that people are living with on a day-to-day basis, and that's what we're trying to support kind of everyone. Obviously, Zoom is the new normal, as we were discussing before we let you all in, and this is what we're going to do for once a month. We're going to have condition-specific webinars. So this time it's about PXE, and then I'll talk about what's possibly going to be next time at the end. So the first person I'd like to introduce you to is Geraldine Hode, who's the research manager for the Macular Society. So if you just want to sort of introduce yourself quickly, Geraldine, that'd be lovely.
Yep, thank you very much. Yep, I'm research manager. So I've been with the Macular Society about 5 years now. I look after the research program, so all the research projects that we fund, which is a big important part of the work we do. But I also liaise with the researchers and with ophthalmologists, and we support research in all sorts of different ways. And so that's about half my job, and the other half is looking after the research programs. So very interested to hear on PXE, because it's not a disease I know a lot about.
Great. Well, we'll let you have a little bit longer at the end to have a bit more explain about what how the research side of the Macular Society works. Is that okay, Geraldine?
Yep, that's fine, no problem.
Brilliant. So we'll catch you a bit later. So Peter, so welcome.
Hello. Hello. Good evening, everyone. So yeah, as Colin already mentioned, I'm a consultant ophthalmic surgeon at the Oxford Eye Hospital. I'm originally from Germany, where I led a clinic for rare diseases, which involved a Center for Celoxanthoma elasticum, which is where my background comes from, that I care for patients with PXE. Should I start with the presentation, Colin?
Absolutely. I was just to say thank you very much for taking the time this evening to talk to us all about this. It's a very rare disease, so I'm very interested to learn about it. So yeah, so over to you. Yeah, great, thanks.
Good. Good. Is it visible to everyone?
Yeah, I think so.
Good. Okay, so it's obviously a systemic disease, Celoxanthoma elasticum, but I will focus on the eyes. So what is PXE? It is a systemic disease, and it is an ectopic calcification disorder of elastic connective tissue. That means that everywhere in the body where you have a lot of elastic tissue, this tissue tends to calcify, become harder, brittle, and dysfunctional. There's an estimated frequency of about 1 in 50,000 people. So in the UK, there should be at least 1,000 patients, most likely more, and we also think that it's underdiagnosed. It's caused by mutations in the so-called ABCC6 gene, and these are the three cardinal features of the disease: an inelastic skin with yellowish papules, cardiovascular disease, and retinal changes. The skin changes are frequently the first sign that leads patients to doctors and that leads to diagnosis. However, it not necessarily is present in every patient. So there are patients who, for example, have only ocular problems or mainly cardiovascular disease, and skin changes are not really the most frequent sign. There are diagnostic criteria for the disease, and they have changed over time. As you can see, there are some major diagnostic criteria, and they include changes in the skin, the eyes, and genetic testing. And if you have two of the major criteria, it allows to diagnose these as PXE. This already shows that the cardiovascular changes are not included in those diagnostic criteria, which is because they're often less specific and often don't cause any problems, at least to start with. So I'm going to talk about the eye changes, and the first description of the typical eye changes that we see in patients with pseudoxanthoma elasticum was reported in 1889 by Robert Doyne, and he was the founder of the Oxford Eye Hospital. So it has quite a history in Oxford, and he was also the founder of the Oxford Congress, which is one of the most or one of the bigger ophthalmological congresses in the UK. It took then about 40 years before the recognition, or before it was understood that it's a syndromic disease where the skin changes occur together with the eye changes, and often also then with cardiovascular problems. And the first doctors who described this was an ophthalmologist, Issa, and a dermatologist, and the name that is often also used for the disease, which is Grönblatt-Strandberg syndrome, has a name from those two colleagues. So why is it important to talk about the eye in PXE? Vision impairment, when we ask patients about quality of life, vision impairment seems to have a larger impact than the cardiovascular disease in pseudoxanthoma elasticum patients. So it seems to be the most worrisome problem of this systemic disease. So how and where does it affect the eye? You imagine the eye like a camera with the lens on the left-hand side in this picture and the film on the right-hand side. The retina can be seen as the film, and you need obviously the film and the retina to take the pictures, to see your environment. This is an en face image, so when you would look through the pupil to the back of the eye, which shows the retina, and on the right-hand side is the optic nerve, and in the middle the macula, and a cross-section through that macula here with a so-called OCT image shows the different layers at the back of the eye. And this is like an histological section, and the inner layers, which are here, are the retina, so the photoreceptors are this dark, broader layer, and then the connecting layers of the inner retina. And in pseudoxanthoma elasticum, the first presentation of the disease occurs in the layer underneath the retina, which is marked here with this red band. And we call that layer Bruch's membrane because of the well, it was again has the name of the doctor who first described this membrane. It's a very thin membrane that lies between the retina and the so-called choroid. The choroid is a vascular layer that supplies the outer retina, so the photoreceptors, with oxygen and other nutrients, and is also necessary to transport metabolites from the retina away, so that it has the environment it needs to be sustained. This membrane now calcifies, and the exchange of nutrients, oxygen, and all the other molecules and compounds may therefore become less easy, because they always have to pass this membrane, which is then calcified. The natural disease cause, if you read about PXE, includes many different findings in the eye, and I just wrote them down here in red. These are the most common findings that most patients show at some point in the disease course. Then there are others who are rarer, and which are on the right-hand side. And then there are the symptoms that patients may experience. They include reduced visual acuity, a central scotoma, which means that everywhere where the patient look at, they have a loss of vision, basically. Reduced vision in dim light conditions, reading problems, distorted vision, and reduced contrast vision. These are basically the same symptoms that patients with other macular diseases may also experience, mainly also with AMD. So I'll just briefly go through the different findings at the back of the eye that we see in PXE patients. And the earliest finding is the so-called peau d'orange. And this just shows this diffuse calcification that happens at the back of the eye. And this image shows the calcification, which is all the yellowish background coloring of that fundus image, which is different to the more reddish color of the normal retina in the further periphery of the eye ocular fundus. And the peau d'orange is just the transition zone between the calcified area and the normal retina. So it basically shows how advanced the calcification process in a given eye is. This can also be visualized with this OCT technology, where the calcification results in a higher reflectivity of the membrane between the retina and the choroid, seen here as this darker interrupted areas on this scan. The next very frequent finding, which you will find when Googling the disease, are so-called unguate streaks. These are lines that appear like vessels at the back of the eye, but they're not vessels, they're just breaks in this calcified Bruch's membrane. And this is just a magnification, so the red lines are real vessels, and this brownish line here, this is a so-called unguate streak. This is another one, and another one. They can again be visualized with the cross-sectional imaging method, OCT. where the breaks may be seen in this hyperreflective calcified line between the retina and the choroid. And this is one such break. This is another one, and this is another one. Patients may develop so-called pattern dystrophy-like changes and atrophy of the RPE and photoreceptors. To explain this briefly, pattern dystrophy just means that the macula develops changes that appear like a pattern on different imaging modalities, and they are precursors, or can be seen as a precursor of atrophy. And atrophy means that the retina, or the outer retina, which includes the photoreceptors and the retinal pigment epithelium, die off. So the cells are lost, and at that point, vision cannot be recovered. There are rarer changes, as I mentioned before, like optic disc occlusion. These are this is material that accumulates in the optic nerve, and no one really understands the origin of this change and why it occurs. It's sometimes also seen in the general population, and there is also a genetic component to this. But there's a clearly more frequent occurrence of these changes in patients with PXE. If they are severe, they can cause visual field changes that are independent from the retinal changes that are due to the calcification process of Bruch's membrane. Then there are subretinal hemorrhages, basically simply bleeding at the back of the eye, as shown here. And one of the causes is that even minor traumas to an eye that is less elastic and basically calcified may cause these bleedings if cracks develop acutely in this Bruch's membrane layer. And for that reason, one of the recommendations for PXE patients is to avoid contact sports, but some things cannot be avoided. For example, this patient just was working in the garden and hit his eye with something in the garden, so without doing any contact sport. Then one of the common changes that may affect the vision of patients severely is the development of choroidal neovascularization. That's a similar process like in patients with wet AMD. So basically, vascular membranes grow from this highly vascularized layer, the choroid, through Bruch's membrane into the space underneath the retina. These membranes can then bleed and leak fluid into the retina or underneath the retina, and eventually may form a scar tissue, which may also lead to a permanent loss of vision. And these pictures just show different examinations or tests, how we diagnose these changes. This is a fundoscopic appearance, or the angiography, where we inject the dye through an arm vein and can exactly see how big these membranes are. There are newer technologies like OCT angiography, where the membranes are also visible, but without injection of a dye. And OCT imaging, so the cross-sectional imaging, also allows to see or to visualize the activity of those membranes. There are effective therapies available. It's basically the same as for wet AMD, so injections of a medication, of different medications into the eye, and with those injections, patients' vision can often be improved again, and in most patients be stabilized over very long periods of time. If untreated, these membranes can lead to large scar tissue underneath the retina, as shown here on the right-hand side, and this is not reversible. One of the difficulties is that in the diagnosis and the decision making whether a patient needs injections into the eye or not, is that very similar changes can also occur in absence or without the presence of these neovascular membranes. So we see, for example, this such accumulation of subretinal fluid in PXE patients without neovascularizations. That's sometimes really difficult to determine where this fluid comes from. Sometimes we just need to try a treatment, and if it doesn't work, we may decide that this is not due to such neovascular membranes and may be left without treatment. And only recently we understood that there is another possible change that may acutely affect vision in patients with PXE, and we call that acute retinopathy. And it's not yet well understood, but there are some patients who develop a relatively sudden change in vision and loss in vision. And we think that it may be an autoimmune phenomenon, so that the immune system also plays a role in these changes. And often patients with these acute vision losses that may affect more than only a central area where a neovascularization occurs, those changes are usually reversible, but it may take often a few weeks or months to recover. Depending on the severity, there may be long-lasting changes. And we have not yet understood well if patients may benefit from immunosuppression in those cases or not in this scenario, because often patients are or possibly not diagnosed correctly with those changes. So what about the symptoms? Reduced visual acuity is certainly one of the main worries. The visual acuity drops in the majority of patients in the 5th to 6th decade of life, so between the 40s and 60th birthday. But there are patients who have good vision even in their 70s. And the graph on the right-hand side just shows the comparison with AMD, where the patients with severe vision loss accumulate after the age of 50 in the PXE patients, and at the age of around 80, the vast majority have significant vision problems, whereas in AMD, this is about the age where most patients start having problems. There's a significant effect of this calcification process on dark adaptation. And many patients have problems, for example, when they go from a brighter room into a darker room, or from outside into a house, or if they're in a restaurant, the contrast vision in dim illumination is very poor. And they often need a lot of light to then see or have enough contrast to read. And we assessed that in a larger patient cohort and found that this decreased dark adaptation gets worse with age, starts around 30, 40, so before even visual acuity changes occur in many patients. And it seems also to be independent or relatively independent from visual acuity loss. So even patients with very good visual acuity may have such dark adaptation problems. So to break it down to some take-home messages, there are the chronic eye changes due to the calcification process, and this determines the natural history of the disease. There are currently no eye-specific therapies to change this natural history. There are acute changes, such as the development of choroidal neovascularizations, these what you may know from AMD as wet AMD, or such autoimmune phenomena. And for those acute changes, there is usually a therapy available that is quite efficient. It's important that in case you have eye problems, especially if they have a recent onset or change quickly, you should have your eyes examined. And what I also want to highlight is that it's important that patients with such a rare disease contribute to research so that we can better understand the disease and improve patient care. Before finishing, I just want to highlight that there are some potential therapies in the pipeline. Just as a quick background, as mentioned initially, PXE is most frequently, at least, caused by mutations in the so-called ABCC6 gene. ABCC6 is a transporter in liver cells that increases ATP in the blood. That's now very complex, but what it eventually means is that although the manifestation of the disease is mainly in the eyes and the skin and the blood vessels, the protein that is faulty is not expressed in those organs. It's mainly expressed in the liver. And what it does is it produces or allows the systemic availability of a compound that results in antimineralization processes. So it inhibits calcification of the peripheral tissues in the eye, the skin, and the vessels. This ATP, which is increased by ABCC6, is converted to so-called pyrophosphate by an enzyme that is also found on liver cells, for example, but also on other cells. So, and this pyrophosphate is the important compound that inhibits the calcification in the periphery. It was recently found that pyrophosphate concentration in the blood is reduced in PXE patients, as well as in an animal model for PXE, so in a mouse where that also has a mutation in the ABCC6 gene. And with those relatively recent knowledge in mind, some colleagues now developed novel therapies that are partially already in trials and are investigated. So one obvious therapeutic approach, if pyrophosphate is reduced, would be to increase its levels in the blood by oral administration, so as a tablet, for example. But the problem with this is that there's only very little uptake of pyrophosphate from the gut, and conversion into inorganic phosphate may even stimulate calcification. So there are now clever ideas how to deal with these problems to increase the uptake in the gut, for example. And this approach is already in a clinical trial, at least to test whether pyrophosphate can be increased in the blood with this approach. Another idea is to use pyrophosphate analogs, which are bisphosphonates. And one preliminary trial was already conducted in Holland, which showed some promising results. And it is not unlikely that a larger study will soon follow. A third possibility would be to increase the activity of the enzyme that converts ATP to pyrophosphate. There are also already studies in the animal model that showed that this seems to work. and this idea is also pursued, and there is the aim to bring this also into a clinical trial. Pyrophosphate is also degraded by another enzyme called TNAP or TNAP, and inhibiting this degradation of pyrophosphate with TNAP inhibitors might also be an approach that could result in a benefit. Then other things that are not yet in or close to clinical trials, but are also clever ideas, are to stimulate alternative routes of ATP release, which would then result in an increase in pyrophosphate. There's also some data from animal models that exercise may increase ATP release, and therefore may also increase pyrophosphate in the blood. And there may be some mutation-specific therapies, which I don't want to go into detail, but they basically rely on the exact knowledge of the specific mutations of each patient. And this just shows that genetic testing is not only of diagnostic value, but may in the future even have therapeutic value. And with this outlook, I'd like to finish already, and I'm happy to answer any questions.
Well, that's brilliant, Peter. Thanks very much. That was really interesting. If you want to unshare your screen so everyone can see you, that would be great. So that was that was really interesting. There's some really good sort of research going on there as well. We like development. Now we're a bit low on the ground today, so I think what we're going to do, if everybody wants to unmute their mics, we're going to try and have some actual people asking some questions. So Denise, are you on the call?
Yes, I am, yeah.
Yeah, do you want to ask your question?
I was born with valvular heart disease. Is this PXE linked to that?
There's no known connection with developmental changes of the heart, no.
That's good to know, thank you.
Okay. Has anybody else got any questions?
I'm Jennifer.
Hi.
Well, what can I say? I'm actually about 29 years ago, 1991, over 3 weeks, I started attending Moorfields because things started going wrong with my eyes. So in that 3 weeks, I went from driving my car and leading a normal life and having a toddler to being registered blind. It has continued the sight loss over the last few years to the point now where I am bouncing off the doorposts in my house. I've had all sorts of mobility training, but it's all just imploding, if you like. And at Moorfields last year, they did say that I was presenting in a very strange way, that I'm losing my peripheral vision as well. And it was presenting more like retina pigmentosa. And I just think, I haven't been asked to take part in a trial. I was not given any injections when they became available for people with wet AMD. And I think I was young enough with a young child to maybe have a bit of help, and nothing was really offered. And it's a strange old disease, PXE, because people see you as a blind person. They don't realize that you've got all these other things going on. And I think generally, you just have a terribly hard time being visually impaired, what the doctor said at the beginning. I can cope with everything. I can cope with all the peripheral vascular disease and all the other bits that are wrong with me, but I think losing your sight is totally life-changing.
It there's very much an emotional impact to that. It's interesting. Is it a usual thing for it to go into the rest of the retina, Peter, or does it generally hit the macular area, or does it go across the entire retina? Is that unusual?
So it always starts in the center, so in the macula, but some patients develop very severe atrophy. We have not understood yet why some patients, it's only few, but some patients really develop widespread atrophy. There might be there might be different factors that influence this. There might be other genetic factors. There may be a tendency to have more aggressive neovascularizations. But there may also be factors like this autoimmune retinopathy that I talked about, which we have only understood and published last year. So there's a lot to learn, and we have not yet understood the entire disease process.
Yeah.
And sometimes it can look like RP if there's very widespread atrophy.
Yeah. So thank you for your question, Jennifer. Has anyone else got any other questions?
Yeah, if I could speak up.
Yeah.
Can you hear me? Yeah. Hello, my name is Hans-Wolfgang Leudel. First of all, thank you for organizing the webinar. I think for all of us with rare diseases, it's really good to get more information about the underlying factors and kind of what's happening.
You're more than welcome.
So well, two questions. I mean, one specific question would be, you mentioned the injections as kind of countering the acute symptoms that come up with it. Could you comment on how effective typically these injections are compared to wet macular disease? Is there different nature of or different kind of effectiveness when it comes from a PXE diagnosed situation?
Mm-hmm. So yes, they are very effective. The difference is that in our experience, but there's not a lot in the literature about this, but those centers that see many PXE patients know that we have to be much more aggressive in how we treat patients with PXE. Mm-hmm. So when, for example, when we would tolerate mild neovascular activity in an AMD patient, we would not tend to do this in PXE. Mm-hmm. So the threshold to retreat and perform more injections should be very low.
That's great. Did you say you had another question?
Yeah, thanks for that. The other one is more, yeah, also a question, but also a comment. I mean, I would be quite interested to get involved in kind of well, clinical trials or research in general, even if it's not clinical trial. I was invited for just a workshop about macular degeneration. My observation, just psychologically being part of the process, even if it's early stages or information gathering, psychologically, I think for us as patients, that's really useful. So can you comment on ways on how to get in touch or be involved in the process?
That's a point that that I find extremely important, and especially, I mean, you said it all, for patients with rare diseases. The problem is that, to be honest, in the UK, there seems to be no center yet for this disease, and the difficulty will be that once industry and companies come up with novel compounds that may have a good rationale to work for PXE patients, they will ask where big cohorts are so that they can recruit quickly for a trial. Mm-hmm. And this is why it's so important that patients and patient organizations are well organized and that patients are well known where they are, so that recruitment can indeed happen. So what we have planned and what we will soon do is to send around or have an online questionnaire for PXE patients in Europe. So we will run that in different countries, and which will give us an idea of the landscape where patients are, how well they're informed on research in the field, how much they know about their disease and what their worries are. And such effort hopefully helps to then also get patients more involved and informed, and hopefully patients then also are correctly diagnosed, are seen at least once in a center where they're then known, and these are all important steps to get the research going for such a rare disease.
It's so important, isn't it?
Yeah, so there might be a way for the Macular Society actually to help with kind of identifying people and kind of plot the landscape, basically, as you said.
Yeah, I think it'd be a good point at which for me to mention. Yes, Hans, we've got something we call our research participant database, which is basically a database where people who would like to take part in research register their details with us, nothing very complicated. And then we've got them, we've got a register of patients with all different types of AMD and all the macular dystrophies and other forms of macular disease. Because I did talk to Peter a few months ago, and I looked on the database, and we only have a handful of people with PXE on it at the moment. But if we could build that number by people registering on the database, that would be great, because we would have that nice cohort of people who we could tell if there was a clinical trial underway. We could flag it to them. So if anybody is interested in signing up to that, you can find a form on our website in the research section, and it's quite simple. You just fill in the online form, and you'll be there, and you'll be registered as a possible candidate for clinical trials should they come about. So that will help us build a community of people which the researchers can come to us and find patients for their trials.
I think it's an extremely important point, and other countries just are good examples how beneficial this can be. So I think the best example is Holland, where the center in Utrecht cares for the vast majority of PXE patients in the entire country. And although it's such a small country, they have several hundreds of patients in their database. So they could already run a trial on these bisphosphonates, because they could recruit in a large enough number of patients in a reasonable time to make it work, and to make it also financially work, because all these trials are very expensive. So there's a very good example how even in a small country with not too many citizens, with a well-organized patient organization, these things can happen.
That's brilliant. We've still got a few more minutes left. So has anybody got any other questions for Peter?
This is Jennifer again. Could I just say something?
Yeah, of course.
All right. All this online stuff, I don't do online. And it is very difficult when you become visually impaired, because I, as a visually impaired person, cannot find anywhere to get any computer training.
All right.
It's really difficult. All this stuff about go on the macular website, well, I can't do that. Fill in an online survey, I can't do any of that. My husband this evening has had to get me onto this webinar, because the world of online stuff is just closed off to me.
Yeah, I tell you what, Jennifer, if you give me a call, Colin at the Macular Society, we can have a conversation about that, and I'll see if we can find you some online training, because my vision is incredibly poor as well, and I use a computer. So it's about finding you a place to get some training. But if you want to join our database for participant database, you can always give our Advice and Information Service a call, and they'll be happy to fill the form in for you.
Okay,
Yes,
great.
we're very happy to do it over the telephone, or we can send out a paper copy to you. Sorry, I should have mentioned the other options.
Yeah, well,
Helen.
I mean, anything in print's a waste of time. I'm audio only.
We could sort that out. Yeah, just give the Advice and Information Service a call, or
Okay, thank you, Colin.
that's no problem. That's no problem.
Colin, can I just quickly ask one more question?
Of course you may.
As a PXE patient, if you've got severe sight loss on your central vision, and the hospital says to you they're going to discharge you, is it advised that you actually say to them, well, can you not keep check on my peripheral vision?
You can, Peter would probably be the best person to answer that question.
Yeah. It's a tricky question because it depends on what affected your peripheral vision. And if the disease process or the progression at that stage is due to these neovascularizations, this growth of vessels underneath the retina, only then any treatment would be, any of these injections would be a treatment option. There are other factors that lead to disease progression. There's atrophy that progresses without any of these neovascular membranes. There may be a role for those autoimmune processes, and it depends on the actual cause of your vision changes at advanced disease stages. And the problem is also, and the Macular Society I'm sure is very well aware of these things, is that treatment with injections for patients that have reached a certain threshold of blindness is often not given anymore because there's no evidence that they have a benefit. I'm not sure how well this is discussed in the Macular Society. I mean, Colin, you might be best to comment on that. But back to your question, there are different causes for progression at late stages, and you can't tell it is not the same for every patient if they might still benefit from any intervention or not.
It's also very important. However, I have significant central vision loss, and I go for regular eye tests because your eye test can also pick up on other health issues. So if the hospital discharges you, there's no reason why you can't go to your local optician every couple of years just to have an eye health check rather than an eye test. We'll have to say that on National Eye Health Week, really. You
have to go to Vision Express.
Go to Vision Express, yes. Excellent.
Should explain why. Really.
Explain why, because every eye test that Vision Express are doing at the moment, they're donating £3 to the Macular Society over the entirety of September. So, which is very generous of them. We're very thankful for that. So, if you need an eye test at the moment, pop to Vision Express and get it done. And even if you don't need an eye test at the moment, pop to Vision Express and get it done. That's excellent. I'm just aware of the time. Peter, I'd like to thank you very much for your time today, and then I'm going to give Jerry just a couple of minutes to say some few more things I'm sure you'd like to. But really thank you for giving up your time today, this evening, to talk to us. That's a very interesting talk. And we at the Macular Society will support you in getting as many cohorts as we can for your studies moving forward, because it's a very important thing to do.
Yeah, thank you for listening. Thanks for the opportunity.
Jerry, do you just want a couple of minutes just to sort of, or have you covered everything that you feel you need to for this?
Well, I've mentioned the research database, which was important. I mean, I've got so many questions, but I'd keep you till midnight, unfortunately. I'm a scientist, I get a bit nerdy about it all. Yes, I suppose for those who might not be aware, I mean, the Macular Society is about support and research, and research is a very important part of what we do. So we have a research program where we fund mostly medical research, but some social research as well, so helping people live with the disease as well as trying to find cures. The way we operate our research is about researchers putting grant applications to us. We are open to fund research on any macular condition, but we tend to mostly get proposals on AMD and the macular dystrophies. So I suppose to Peter, we'd love to get applications on other forms of macular disease where we've never funded research before, and PXE is one of them. So a lot of my messaging is out to the research community that we're very open to take applications on all types of macular disease, not just AMD and dystrophies, and some of these rare ones. It would be lovely to be in that space as well.
Brilliant.
Thanks a lot, but we need to see the patients first.
Yes, well, yeah.
Yeah.
Yes.
Chicken and the egg, isn't it? Chicken and the egg. Okay. Brilliant. Well, I think that's our time for this evening. Again, thank you very much for your time, Peter. That's been great this evening. Thanks very much. Mr. Andrew Webster from Moorfields is the next one with his My Eyesight project, which is a database where you only have to give your information once, which is very exciting. But he'll explain that a lot better than I just did. So that's it for this evening. So thank you for joining us. And if you want to join the next one, it would just keep an eye on the website and social media. And if you need to speak to the Macular Society Advice and Information line, it's 0300 30 30 111.